Are we ready?
I'm ready.
Yep. Okay. I'm just watching the number of participants joining us. Okay. Sanchia, you okay?
Yeah, Boone, I'm fine.
Okay, good. I think we shall make a start. I can see that we have 54 and increasing number of participants, 55, 56. Okay, let's make a start. So this is Boon Chua speaking. I'm the Director of Cancer Services here at the Prince of Wales Hospital and a Professor of Medicine at the UNSW Faculty of Medicine. So I'd like to welcome everybody to roundtable session today on the financial toxicity of cancer. And I am delighted to introduce our facilitator for this session, Professor Sanchia Aranda. And Sanchia is someone who I've known for many years. She's currently the Chief Executive of the Cancer Council Australia, and she's also the immediate past president for the UICC. So thank you and welcome, Sanchia. And I also like to welcome our speaker for the day, Professor Stephen Jen. And Stephen is the co-director of the Health System Science at the George Institute for Global Health. And he's also the conjoint professor of health economics at UNSW Sydney. Very experienced researcher in this field. So I'm delighted to have his expertise to share with all of you today. So over to you, Sanchia, please.
Thank you very much, Boone, and it's my great pleasure to be facilitating this session today with Stephen as the speaker. Stephen and I've had a number of interactions previous to this about this matter, but I'd like to begin by acknowledging the Bedegal people of who are the traditional custodians of the land on which the facility for the webinar sits, but I'm sure we're all sitting on a range of different lands. And I'd also like to pay my respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people who may be present today. I'd just like to begin with a little bit of context about why this topic of financial toxicity is so important. We know that Australians who live in the most disadvantaged communities in Australia have increased risk factors for cancer, that they participate less in early detection initiatives, and that they have poorer cancer outcomes. We know that they have a 37% higher age standardised mortality rate from cancer, and they're more likely to also die from preventable cancers related to things like higher smoking rates. And so when financial toxicity occurs, the impacts can be fairly profound and can impact on overall cancer outcomes. So I'm delighted to have Stephen start his presentation. As you all know the format for this, so we'll work through a range of topics, alternating with some Q&A in between. So I'll hand over to Stephen to begin.
Thank you. Thanks, Sanchia. Thanks, Boone. And thanks, everyone, for dialing into the presentation. As Boone says, I'm a health economist at the George Institute, and we've actually had quite a significant program of work looking at this issue of financial toxicity, out-of-pocket cost, household economic burden, whatever you want to call it. Large part of that work has been done overseas in low and middle income countries, particularly in the Asia Pacific region. But some of it has also been done in Australia. And what's become more and more sort of apparent to us is that this really isn't just a low income country issue. Even in countries with good healthcare systems, with strong national insurance programs like we have in Australia, people do fall through the cracks and experience significant economic burdens, and that's what we've been looking at in a lot of the research that we've done. And so just the outline of the presentation today, I've got 5 issues I want to address. So one is about the impact of financial toxicity, and then the impact of out-of-pocket costs on treatment decisions, what systems are in place to support people, and then the impact of COVID, and then at the end, I'll talk about some future directions in research and policy. So what's been the impact of financial toxicity on people with and their families? So I suppose the initial background to this is what I can present here is the level of out-of-pocket spending that we incur in Australia compared to a lot of other sort of countries in the world. And this is an OECD comparison, so it's mainly high-income countries here. And you can see here that we're a little bit below the rest of the OECD. The average is around 20%. We're at 18%, but we're below a lot of the countries that we tend to like to compare ourselves with. So countries like the United Kingdom, New Zealand, and a lot of the countries in Western Europe. And this level of 18% is often a surprise to people, and it's been like that for the last probably decade or two. Historically, before that, we had lower levels of out-of-pocket spending, but in the past couple of decades, with the advent of greater private health insurance, that's really sort of bolstered up our level of out-of-pocket spending. In relation to cancer, the one thing I've came across most recently was a report done by the Consumers Health Forum that looked at this issue of out-of-pocket payments resulting from cancer treatment. And here's a quote from the report that sort of highlights, I think, nicely the issue. So there are three aspects to this finding. So more than a quarter of those having treatment for cancer who responded to the survey incurred cost of more than $10,000 in 2 years. So that's so of the 1,200 that responded, 1 in 6 reported costs had a significant impact on their lives, and some having to draw on superannuation. And well over a third of respondents said that no one had discussed the possibility of these costs with them. So there's really sort of three key aspects here: the high level of costs that people incur, the long-term impact that this has on their financial viability, and the fact that the information about this is often not given to people. And these are some of the issues we'll turn back to during the rest of the presentation. But before that, I just want to present very briefly a piece of research that we did that highlighted this issue. And this was done overseas. It's part of what we refer to as the ACTION study. It was a study that was done in Southeast Asia in people with initial diagnosis of cancer. And the outcomes that we were looking at were financial catastrophe, treatment discontinuation, and death. And so what the aim of the study was to determine the economic burden on households, on people with a first-time diagnosis of cancer. It was a cohort study. There are 4,500 consecutive adult patients we looked at. It was done across 47 hospitals, and we interviewed people at baseline and at 12 months. And the outcomes that we were interested in, sorry, not 12 months, at 3 months. So the outcomes we were interested in at 3 months were people who were hospitalized but experienced some financial catastrophe. So we classified that as out-of-pocket costs that exceeded 30% of their annual household income. People who were hospitalized but experienced no financial catastrophe, so that was considered the reference outcome, the good outcome. People who experienced no hospitalization because and discontinued treatment. So these are people who were indicated for surgery but have failed to continue with their treatment. And fourth outcome was death from all causes. And just in summary, the outcomes that we found were that 31% of patients incurred financial catastrophe, 8% had died, 23% had discontinued treatment, 38% had the good outcome of continued treatment and avoided financial catastrophe. So I won't go into too much detail about the results, but here are some of the sort of more nuanced findings. The women had a higher risk of financial catastrophe than men. health insurance was found to be significantly associated with a lower risk of treatment discontinuation. As you would expect, income had a lower risk of death, lower risk of financial catastrophe, treatment discontinuation and financial catastrophe. And lower education, not being in paid work, experience of economic hardship at baseline were generally associated with high risk of death and treatment discontinuation. So a lot of these findings are probably not too surprising to you. Perhaps the one that is surprising is around the women having a higher risk of financial catastrophe. So some of the conclusions we came up with, health insurance protects people from financial catastrophes, encourages the continuation of treatment. Cancer and the need for surgery results in a many-fold elevation in the risk of financial catastrophe in Southeast Asia when you compare that with the general population. Women are particularly vulnerable to financial catastrophe, and the socioeconomic disadvantage are also vulnerable to adverse outcomes. So as I said, a lot of that is probably not too surprising. But one of the interesting sort of postscripts from that study was that it was cited in the debate in Philippines Parliament when they introduced a new bill called the Integrated National Cancer Control Program. And I think that's one of the values of this sort of research is that even though it's not particularly complex, it doesn't find anything often that's all too surprising. It often has a very powerful sort of policy and advocacy message, and I think it was quite effective, at least in this setting, in leveraging some of the arguments that were needed to support this bill. So I'll leave it there for the moment, and I'll go into the other issues in a sec.
Okay, so if people have questions, then please put them in the Q&A session. But Stephen, there's a question asking around what proportion were sort of drug costs or indeed non-PBS approved or more experimental medications. So do we have any information about that in either the Australian context or indeed the international context?
I can't remember what proportions of I mean, most of the costs that we measured in the action study were the hospitalisation costs, and they were the main contributors to the financial catastrophe. So that was what we were really interested in, is that 3-month cost post-diagnosis hospitalisation. But in Australia, one of the safety nets that we have around sort of medication costs is the PBS safety net. So that means that you have a limit. I think it's about $1,200 a year in terms of co-payments, and once you hit that limit, then your level of co-payment then reduces substantially. But of course, there are some cancer drugs that may not necessarily be on the PBS. And there may be certain treatments associated with cancer that people may sort of incur that aren't necessarily reimbursed through Medicare. That's where often those costs pile up.
Yep. And so I think there's quite a lot of questions about that detail, and in fact, because a lot of this work is actually patient self-report, it's not going into that level of detail, and remembering it also covers off on pretty much only the health-related costs, when in fact the costs of being unable to work or to have extra heating or special diets or other things are less covered. Stephen, there's also a question about whether or not you're seeing the same gender difference in the Australian context versus the international context.
We haven't personally looked at that issue in an Australian context, and I will cite a study later on in this presentation where we have tried to explore the gender dimension in relation to treatment discontinuation, or the term I think is treatment abandonment in paediatric cancers, and we've tried to sort of explore the issue of whether there is a gender bias there. But in the Australian context, I'm not aware of any research that's looked at that.
And there's another question about private health insurance, and we certainly know that private health insurance usually relates to higher out-of-pocket costs, and we know that women with breast cancer and men with prostate cancer carry some of the highest burden of those costs in that Australian context. There's also a question about pathology, and certainly we get a lot of, at Cancer Council, get a lot of questions related to the costs of not only pathology but also radiology, where patients are often sent out of the hospital for their tests, not really understanding that those are costs. So we can cover back on some of those. But I'll move you on to the next section if that's
sure.
okay.
Okay, so the next question we're looking at is what impact do out-of-pocket costs have on treatment decisions? And you would have seen in the previous lot of slides when I talked about the ASEAN, the action study, that we did come across a fairly high level of treatment discontinuation in Southeast Asia in people with surgically operable cancers. I want to now sort of look at some of the data that we found in Australia. And this is a study, it's not cancer specific, it's cost related non-adherence to prescribed medicines among older adults. It's based on a Commonwealth Fund survey, and it's comparing 11 countries and high income countries, and Australia's in there. And as you can see in this slide, if you look at the findings, the highlighted bit in particular, you can see that we generally have twice as high odds of non-adherence to medications as the reference case, which is the UK. But we're also higher than a lot of other countries on that list. When we look at low income, by income groups, we can see that effect is even stronger in people below average incomes. In terms of other aspects of treatment decisions, and this is a study that we're currently, it hasn't been published yet, but we've just completed. It's a systematic review and meta-analysis. And this is what I referred to earlier. It's looking at the issue of treatment abandonment in children with cancer. And the particular issue we wanted to explore is whether there was a sex difference. And this is based on evidence in low and middle income countries. And so, yep, we did a systematic review and meta-analysis. The punchline for the study was that what we found was the pooled rate of treatment abandonment was around 30%. So 30% of people who start treatment abandon care. And we observed, but our hypothesis that there might have been a gender difference was not confirmed. So we found no observed difference in the proportion of treatment abandonment in girls relative to boys. However, we did find a number of risk factors that might explain treatment abandonment, and these can be classified broadly as socio-demographics, in other words, income and poverty, geographic, and travel related. So even though we didn't find any effect and a gender effect, I mean, what we can take away from this review is essentially that treatment abandonment seems it seems remarkably high, 30% in these populations. And I suppose it raises the question of why did we look at this issue? And my feeling is that financial protection for particularly in low and middle income countries, this whole idea of universal health coverage really does have an important gender dimension. In households where there is a potential for high levels of out-of-pocket costs resulting from treatment, and where there are gender biases in terms of the ability to of females within that household to access household resources, then there's the argument goes then if we provide universal health coverage, then there's potentially a strong gender dimension to that, and that we may be able to address some of the gender disparities in health outcomes. And so that sort of was what prompted us to look at this question to begin with. So I'll leave it at that and see if there's any questions.
Thanks, Stephen. And there are a couple of questions. So was there anything that would suggest in the research that you've done that non-adherence is explainable by costs, or might there be other sociological factors or issues that are going on?
I think there's no doubt there's a range of other sort of sociological stigma issues as well. Perhaps less so in, I mean, cost is certainly positive, because there's often, with some of these studies, there's also some supplementary sort of qualitative or explanatory sort of evidence presented as well. And it's very clear that the cost is a major driver, but there's no doubt there's a whole range of other sort of social factors.
Yeah, there's also a question around geography and travel, and I know that work that was done in Queensland some time ago showed that certainly optimal care was impacted by travel. So looking specifically at rectal cancer and whether or not neoadjuvant radiotherapy was used, and it was something like 8% increased mortality for every 100 kilometres from the radiotherapy centre. So we know there are those. Did you come across geographical questions in that?
Absolutely, yeah. So that was a key driver of treatment abandonment in this in the studies that we looked at, and the thing is that that's not going to be solved by universal health coverage as we conventionally see it. We typically, when we talk about universal health coverage, we don't necessarily talk about reimbursement for travel costs, and so what that sort of suggests is that that if we are talking about universal health coverage, it's got to be in a broader sense. There's got to be sort of an idea that we not only provide financial protection, but also access to services on a geographical basis.
Yeah, and the whole question about gender bias might be in there, but in fact, one of the differences about UHC in a low-income country context is it's not like our UHC where most things are covered. It's often defined by what's possible, and if you look at the WHO best buys, in fact, many of those are biased towards cancer treatments in women, such as cervical and breast cancer, because there are high levels of curative capability. So you may actually see gender biases the other way, where because men might be more likely to get lung cancer, for example.
Sure.
There's also a question about whether you saw anything around the long-term impact on cancer survivors of financial catastrophe.
Sorry, long-term effect on survivors?
Yeah, the long-term impacts of financial catastrophe when people survive their cancer.
Yeah, no, we haven't looked at that, and I mean that would be a really interesting issue to explore. But yeah, wasn't something that we covered in our review.
Yep, great. Okay, well we might move in. No other questions at the moment, so we might go on to the third section.
Sure. Okay, so the third section is what systems exist to support people experiencing hardship, and I mean, and here I want to largely focus on what's available in Australia. And aside from the obvious things like, sort of Medicare and the safety nets in Medicare and Centrelink, I wanted to sort of highlight a couple of a particular program that I'm familiar with that's delivered through the New South Wales Cancer Council. But before I do that, I mean, this is an issue that's been around quite a bit, and you might recall at the last federal election, the Labor Party had a platform of co-payment relief for cancer, and I think they promised around $200 million. It was a bit debatable whether that was all completely new money or whether it was sort of recycling old money, but it's obviously an issue that has a lot of sort of political resonance. And but in terms of what's available, the one thing that I'm familiar with is and I'm sure Sanchia be able to provide a bit more information about this. This is a service that's available through the New South Wales Cancer Council. It's called the Pro Bono Service and has a number of aspects to it. So one is a legal referral service. So it covers things like wills, superannuation, employment, credit, centre link and tenancy. There's also a financial planning aspect to it. Workplace referral service. Also a service for people with small businesses. And also financial counselling, helping people to manage their budgets and debts, assistance with creditors, mortgage and consumer rights. And there's also some emergency assistance that's available to people up to $350. So that might also be available to provide people with home help as well. So in terms of one of the, I suppose, myths about what's available for people is this idea that private health insurance might potentially protect you from the costs of treatment. And in many respects in Australia, the opposite seems to be the case, that people with private health insurance often are faced with higher levels of out-of-pocket costs. And this comes from that Consumer Health Forum report. I've got a couple of quotes here that I want to sort of highlight to you. One is from Melissa, who's a person who's undergone IVF as well as experiencing breast cancer. And she sort of highlights the gap costs associated with breast surgery and then a whole range of other sort of appointments that she's had to make for both cancer and IVF. There's another quote here from a guy named Jeffrey who's obviously got some comorbidities, and he sort of suggests that we were given printed costs with refunds we would expect to get, but the gaps came to $11,000. I was in so much pain that I had to go ahead with the spinal op and recently carpal tunnel op. So the gap being around $10,000. So it's very clear that often when people are accessing the private health insurance, there's a significant burden that isn't covered by their policies. And that's been borne out most recently also by a study by colleagues at Sydney University, by Farhad Youssef and Steve Leader. And they looked at some data, the household expenditure survey data. And I suppose the punchline for their study was that households with private health insurance spent fourfold more on healthcare than those not insured. So out-of-pocket expenditure on healthcare as a proportion of total expenditure on all goods and services has increased by more than 25% between 2009 and 2015 and 16. So out-of-pocket spending's both going up, and those with private health insurance are spending a lot more out of pocket than people who don't have private health insurance. So I'll leave it at that, and happy to take questions.
Sure, and I just wanted to make a couple of other comments as well. So one of the other things that I think is not always understood is that some years ago, sickness benefits got rolled into the New Start payment system, and so people who have cancer and go on to sickness benefits actually go on to New Start, so they get the same amount as we've been, hearing about pre-COVID-19 and the sort of Raise the Rate campaign. And the sort of narrative that exists around New Start payments is that they're a safety net or a support payment for people who tend to be younger, tend to be unemployed, but in fact in the employment market. So if you're sick, you get the employment obligations, mutual obligations waived. But currently 43% of people who've been on New Start up until the COVID-19 issues were in fact had those employment obligations waived. So they were either sick, disabled, or had children under school age. And the average age of people on New Start is more like around 50 than it is around the sort of 22-year-olds that are in the narrative around this. So I think we really have a problem in the fact that when people are sick, they go on to these quite low payments and are kept well below the poverty line in that context. We also have lots of problems with the New Start system from a cancer patient perspective, and that is that you have to often attend in person. There's no case management process. And so we hear stories all the time of people being taken off their benefits because they haven't been able to make the visit in. And you can imagine during COVID-19 that's going to be even more profound as people don't want to make those sort of trips to often queues and other things. And you have to be able to navigate quite complex online systems, and that's one of the reasons why our pro bono financial and legal service assists with those kinds of complexities. And I know when my niece was diagnosed with advanced cancer and needed to go on to New Start, she filled in the wrong forms the first time around and had to go on to permanent disability, and then the whole process starts again and there's no sort of capture. So I think we really, you know, as patients come before us on these systems, we need to understand the amount of stress these kinds of experiences put on them. So have we got other questions coming through on this issue? Because I think it's a really interesting question about how attuned we are to picking up the patients in our health system who might be on the cusp of experiencing financial toxicity, and therefore put these sorts of processes and evaluations in place early. So we've got a question here that, considering costs with and without private health insurance, does the analysis account for potential differences in access to services? I guess that's also, you know, about rural, remote. And do people with private health insurance access more specialist services, or is the cost higher for identical services? So is it about a charging rate, or is it that it really is that the insurance doesn't cover these?
Yeah, I mean, there are obviously some positive benefits of having private health insurance in terms of access to a specialist that of your choice, private hospital care. It's dependent also on what condition you have and the urgency, and for many people where there's an urgent case for surgery, for instance, then the public system will enable you to immediate access to care. So from that point of view, there's clearly something that you're getting from private health insurance. It's whether the additional cost, the additional value that you're getting is necessarily, and whether you're taking up private health insurance fully aware of what you're up for in terms of treatment, which is often the issue at play here.
And certainly the government has tried to put a few things in place by creating the bronze, silver, gold categories of insurance, so they are comparable across providers, but in terms of what's covered, but the out-of-pockets might not be transparent. So the AMA, for example, have done an analysis for obstetric confinement that showed that the answer to the question of out-of-pocket costs had 34 different answers depending on your insurer and your level of insurance. And so as the layperson navigating that, it's pretty tricky. How transparent, Stephen, do you think these healthcare costs are to the general population? And where can people access this more centrally? Where does the duty of care lie? So I think you're going to move on to that.
Yeah, definitely. There'll be a few slides that we discuss that, and so maybe we'll reserve that discussion.
Yeah, well, we might flick into that one, because I think the other question is also, are there any studies that look about the awareness of support services and how do patients navigate this complex system? So I think some of that comes out in this next section.
Yeah. I mean, I think there's increasing awareness that it is a problem, and the resources are now starting to be generated. So we'll talk about that at the end.
Okay, let's move on to the next part.
Okay, so the fourth issue is what's been the impact of COVID? And I sort of did a bit of a search of the literature. Some of it is not actually even published. But what seems to be the norm these days is that people are putting up their studies before they've been finally accepted in journals. So one study I found, it was a modelling study. I'm an economist, but I also have a degree of skepticism often around modelling studies. But this is an interesting study. It looked at, it's based on a review of the literature and sort of extrapolating from that, what are the likely impact on financial toxicity in cancer survivors. It was a study done in the US, and it found that basis of the evidence that's already out there, and I'll just read that sort of highlighted finding. So cancer survivors, especially patients with head and neck cancer, have been disproportionately affected by rising unemployment levels and economic recessions in the past, both of which are linked to cancer mortality. So it's clear that there's likely to be a significant risk in terms of the burden that cancer patients are going to experience as a result of COVID. Another study that was done, and this is something that many of you may have come across. It was a very high-profile study looking at the impact in the UK of COVID, not so much in terms of financial toxicity, but more in terms of people's ability to access treatment or screening and treatment. And that the finding was essentially that they looked at 5 main cancers, but for 4 of these tumour types, these data correspond with 3,291 to 3,600 additional deaths across scenarios over 5 years. So in other words, what they were modelling was that people would potentially delay screening for these cancers, and the upshot was that we would experience over 3,000 additional deaths from these cancers. Here's a study that was done in Australia, similar sort of question. So it was looking at the excess mortality and health economic impact. It was done by a team at Melbourne University. Hasn't been published. This is just a monograph at this stage. But the conclusions that they found from their modelling was that a 3-month delay in diagnosis and treatment initiation due to the pandemic predicts nearly 90 excess deaths and 12 million excess healthcare costs in Australia over 5 years for patients with 4 cancers. So if delays increase to 6 months, then 350 deaths, $46 million. So yeah, so that's I'll leave that there and see if there's anybody got any questions or comments.
And it's probably worth adding that, so we've been interacting with quite a number of the jurisdictions over the impact of COVID-19. And so from a national perspective, the 6-month pause in breast screening is likely to have an impact in terms of potentially stage shift. What we know in New South Wales is there were 50,000 delayed screens, and so that has potential. But in Victoria, there's a 37% reduction in breast cancer diagnoses coming through the registry, but that there's huge interstate variation. So we're not seeing, it seems to be directly related to how much impact there's been. Nationally, we saw cervical cancer screening rates go down, and presumably because people were not attending their GP. But conversely, bowel cancer screening rates went up slightly because I guess people were stuck at home and looking at that kit sitting in front of them and maybe more compelled to do it. But interestingly, there were also some positives. So the biggest positive for the context of this conversation was the impact of this JobKeeper supplement to unemployment benefits, where we've had a number of interactions now with patients who are saying things like it changes their ability pay their bills, reduce some of their debt, eat twice a day instead of once a day, be less careful about what they're having to spend on food. And so, you know, that's one of the reasons why Cancer Council's been really supporting the Australian Council for Social Services in trying to keep the level of unemployment benefits at a rate that is at least closer to being above the poverty line than it currently is. So there's less about the cost and more about health policy, recommendations to encourage access and attendance. So there was certainly, I think, you know, for those of us in cancer, we know that the services stayed open for Category 1, but that seems to be a problem with public perceptions. Did you pick up any of that in the literature that you looked at?
No, I didn't see anything like that in the literature that I looked at.
We've certainly done a lot of active communication about trying to encourage people to say, if you are sick, you know, still attend your doctor. But of course, while there was a big shift to telehealth, in general practice, that was 80% by telephone, not by video. And so it's much harder to do a clinical assessment by phone. And, you know, I think there are some real concerns about whether people have delayed. And we know that in stroke, for example, there have been people who, and heart disease, lower ambulance call outs for those things and people delaying, which is incredibly concerning for a wider chronic disease perspective.
Yeah, I mean, I'm sure it's not just at the front end of the treatment. One of the things that Boone and I sort of talking about, and I'll talk about studies, perhaps there may be impact on rehabilitation and survivorship services as well, and people's ability to sort of access those because of social distancing rules and fear of infection.
And again, that's been an interesting, one of the upsides for rural patients was that those kinds of support allied health services access increased because of the new telehealth items, which, you know, we're certainly advocating for retaining some of those so that that notion of a patchy experience of benefits and downsides to COVID-19 will be quite complex to look at, I think.
Absolutely.
Yeah. Okay, well, we shift on to the last one because I think some of the questions that we've got sitting here really is what you cover off in this next.
Sure. So the last one is just future directions in research and policy. And this is what I just mentioned a second ago. One of the areas of research that I'm particularly interested in, along with Boone and her team, is doing an evaluation of the cancer survivorship service, and in particular, working with patients and families to understand what are the challenges that they face in terms of cancer survivorship, and potentially highlighting some of the social and economic challenges. There are potentially resources that people can access, and at least through this sort of service, we might be able to sort of open some doors for people, for instance, to the Cancer Council stuff that we talked about earlier. There's also been you may be aware that there's a whole sort of push towards value-based healthcare, and as part of that, there's recently there's a review of the MBS. I was involved in that. I know Sanchia was involved in it as well, and just looking at you know, what existing areas of spending are essentially value for money, and where our priorities should be set in terms of cancer treatment. And I think that is important, not just from the point of view of protecting the government coffers, but also in preventing people from spending their own sort of money on things that may not necessarily represent good value for money. I think in terms of policy directions, on a very sort of broad level, there needs to be a little bit of a reset, and this is goes back to the earlier slide that I presented, that we, you know, we really do have a high level of reliance on out-of-pocket costs as a way of financing healthcare in Australia. It's currently at 18%, and it is something that I mean, I know that there've been a couple of Senate reviews in the last decade that have looked at that, but really we haven't made much of an impact on out-of-pocket costs on an aggregate level. And a large part of that is because we've been heavily reliant on private health insurance and the gaps in payments that come with it. So I think that requires a much broader sort of policy discussion about the direction in which the healthcare system in Australia is heading. And these are issues that aren't just specific to cancer, but to the health system in general. And the final area I sort of wanted to raise is this idea of informed financial consent. You know, that what we've found in a lot of the studies so far is that people not only experience a high out-of-pocket cost, but they often don't know about it going into when they're making their treatment decisions, and are only sort of experiencing this shock when it's too late, when they've already sort of incurred the cost. There was something recently in the media about a liver surgeon who is sanctioned by the medical authorities for failing to inform one of his patients about the costs associated with the private medical treatment that they were receiving, and the fact that the patient wasn't fully informed about the availability of a public, free public hospital option. So one of the initiatives that's been developed recently is something from the AMA, and this is a statement basically around informed financial consent. And you can see in that slide, it's a collaboration of a whole range of other sort of peak organisations, and it's a way of sort of developing a code of practice around the level of information that patients should be getting when they're making sort of decisions that are going to have a financial impact on them. One of the resources that are now available is this thing called a medical cost finder, and this is something that's been developed by the Commonwealth Government, and it enables you to sort of compare costs and work out what you should be paying for certain things. And I think this is one step along the way to informing people. I mean, some would argue that this sort of thing shouldn't be necessary. This is a way in which we're sort of sanctioning implicitly a consumer-based healthcare system. Maybe if we had a system that provided genuine universal health coverage, then this sort of thing would become redundant. But for the time being, I mean, this seems to be an important resource, given the fact that a lot of people are experiencing bill shock or financial toxicity without sort of being aware that they were falling into this trap at the outset of their treatment decisions. So I'll leave it at that and look forward to some questions.
Okay, and I'll just make a few comments about this. So people may be aware that Cancer Council, along with a range of other collaborators, principally initially Breast Cancer Network Australia, Prostate Cancer Foundation and Canteen, also developed a standard for informed consent, and it's a little bit different to the AMA's statement. One is that the AMA statement's predominantly focused on doctors, but it also uses the may language quite a lot. So the doctor may do some things, and in particular, I think for cancer, it's the sense of the context of the wider treatment journey that's often a problem. So people start on a private out-of-pocket cost journey, get into an engagement with clinicians, and then feel it very difficult to go back into the public system. And so that sense that people need an awareness of the wider cost profile of the treatment plan that they're embarking on over time. There's also in the AMA document a requirement for the patient to be the person who contacts the other doctors, and we had some feedback on our standard around the fact that it would be anti-competitive if a surgeon, for example, gave a quote or an estimate of the costs of the anaesthetist. But we've had some advice from the Australian Consumer Competition Group, the ACCC, to say that that would not be considered anti-competitive in that wider context. So that's really important. And I think the other, the piece in this is the big question about the egregious fees. And so the medical costs finder was really the government trying to address particularly those outlying costs, very high bill shock that a minority, and it really is a serious minority of private clinicians charge, but which really need to be called out by the profession. And I'm not sure how many patients will actually navigate their way to the medical cost finder, and it'll be interesting to sort of suss that out over time. And Stephen mentioned the sort of notion of value-based care, and I'm involved in a Centre for Research Excellence at UTS with another group of health economists, looking at whether bundled payment systems might provide a better opportunity to actually fund healthcare in a different way that let all of these cost issues be addressed. So I'll move us over to some of the questions. So someone's asked, I'll go with the last one that's here first, which is there any move to mandate informed financial consent? And if I might just play with that one a little, because I think one of the things is that in the current definitions of informed consent, most of them are silent about financial consent. And so part of what the AMA work and the work we've been doing is to try and normalise it so it becomes what the reasonable person would, or the reasonable clinician would do, as opposed to being a mandation in law. So we've been working with legal groups to do that. I don't know if you had comments on that, Stephen.
No, nothing specific to add. I mean, I've got personal experience. I remember going to a dentist once and being sort of in the chair and mouth open, and the guy says, "You need a new filling," and he's just giving me quotes for whether I need various procedures, and he kept telling me while I was in the dental chair how much it was going to cost, and I thought I was taking financial consent to a sort of extreme degree.
whereas my dentist actually gave me an assessment that I had to go for an assessment visit, and then he gave me a written quote for all the things that needed to be done, having not been to the dentist before. There's another question on a value basis. Where do you think survivorship needs, such as access to exercise, physiology, dietitian, fear of recurrence, psychological services, occupational therapy to return to work, kind of sit in this conversation where their value proposition, I guess?
Well, I mean, clearly that a lot of these things aren't fully funded through the health system. Some of that stuff might need to be funded through private insurance, but often, as we said, that there's a high degree of deductible. So you often face with significant gap payments when you're accessing those sorts of, I suppose, allied care, rehabilitation type services. So that is often where the burden of, I mean, we have a core set of services that are generally funded through Medicare, hospital-based services through the public system, generally free. It's really often those things that occur outside the hospital, that occur in the rehabilitation phase, that where people really sort of build up their out-of-pocket costs.
Yeah. And in fact, we had a conversation recently with one of the private insurers who also talked about the fact that at the moment, legally in Australia, they can only fund things through private insurance if they are indeed hospital stay substitution. So things like at-home rehabilitation, whereas survivorship care probably doesn't fit into that. But they would like to be able to do that because for them, keeping people healthy helps to prevent them from using other services into the future. And so that is a balance, I think.
I've heard that said about primary care as well, that one of the frustrations that private health insurers, well, the people I've spoken to in private health insurance industry, is that they're not able to fund primary care type services. And these are things that are going to keep people out of hospital, going to stop or prevent people from making sort of claims. And so as from a business case point of view, it would make sense from their perspective to be subsidising stuff that happens in the primary care setting, but they're not currently able to do that.
Mm. Yeah, I think that's important. And it also, you know, my background's in nursing. It also happens in terms of where you might look at medical substitution services, where the funding models just don't enable that in most parts of the world. I think we've answered the question around the centralised website. So one exists, but it's confined to medical costs, and I think it's also confined to the practitioner's top 10 claim items as well. So it's not complete or comprehensive.
Yeah, I don't know about you, Sanchia, but I do feel a little uncomfortable about these sites. I think it's a good resource for what the problem that it addresses, but it does sort of push us, I think, into that sort of US-style consumer-based health system, and I just have this sort of overarching sort of concern that this is another tool. It's like a bit like those sorts of websites that come up where you can sort of do those sort of Google reviews of your GP
and we certainly, or I certainly said to the Minister and to the Chief Medical Officer at the time that I wasn't overly comfortable with it, because I also think it's one of those things where clinicians might look at it and say, well, I'm going to, Joe Bloggs, who does the same as me and I'm better than him, he's charging more. You know, does it actually rise everything up to a common denominator rather than give a true comparison? And you know, you have to be a fairly health literate consumer to make your way there to kind of, so I'm not sure. I think it might be a necessary but an insufficient solution to managing the complexity of what we're trying to deal with. There's another question or comment, and I think, Stephanie, correct me if I'm wrong, but I think we can open it up for these last couple of minutes if anybody does want to add a comment. But I think there's a comment here that says access to care is unequal across the public system. Value-added activities such as things like care coordination, MDTs, are often not adequately funded under traditional payment models, and this can potentially turn up or drive up the costs. I'm not sure if you've got comments.
Oh, no, just other than to agree, yeah. Yep, I think, yeah.
And in fact, you know, in relation to that comment on the MBS cancer review, we tried to build value into some of the conversations around some of the items, and particularly the reform of the MDT item. But really, it wasn't about that at all. It was about item reduction and simplification. It wasn't really about reform. Is that how you experienced it?
Yeah, I agree, Sanchia. I think my experience on the MBS review is that it was very much about sort of lower hanging fruit. What they wanted to take things off the list that were either unsafe or had basically no clinical value. I think on issues around value for money, they were a bit sort of bit shy. There really was more about the no-brainers, the things that, you know, that they definitely shouldn't fund. Maybe the next step is to then sort of consider broader issues around cost effectiveness and value for money, but that's going to be a lot more controversial.
And just a final question before I pass back to Boone. Do you think the differences between public and private healthcare are really understood by the patient?
I don't think so. I think given the high rates of private health insurance coverage in Australia, I think people are starting to become more aware that of value for money when it comes to private health insurance. But at the moment, I think a lot of the arguments is driven by fear and a fear of missing out, and maybe there's parallels with the whole sort of education debate as well, and private education and that sort of thing.
And certainly COVID looks as if it's dropping insurance rates, and Winston makes the comments also dropped lower value interventions. And so that, and Boone might like to comment on the rapid shift to hypofractionation in radiotherapy is one of the great examples of that. But, you know, thank you, Stephen. It's been a terrific day, and I'll hand back to Boone.
Thank you.
Okay, I hope everyone can hear me. So thank you, Sanchia and Stephen, for sharing your knowledge and your perspectives. I think has been a very informative and yet sobering session. It's going to help me look at it a lot more critically on these thorny issue of financial toxicity. I've been thinking about what we can do in a collaborative manner to make some progress and deliver some solutions for our patients and their families. I think almost certainly solutions would be complex and would require a whole system approach involving the governments, the entire spectrum of the health sectors, the community organizations, the not-for-profit organizations, and also particularly involving our patients and their carers. I think the difficulty, of course, is having the right data, having the right methodical and considered approach in making some progress, and it will be in stages. I think this is going to be a long-term challenge for us with the ever-evolving the various treatment options available to our patients and beyond the acute care setting. So I think this highlights the importance of research, which I'm sure that many of us will feel very passionate about. So I encourage all of you who have ideas or would like to be part of an academic the progress to please get in touch with Stephen and Sanchia and myself, and we're happy to put you in contact with relevant individuals. And I think this would have to be the way forward. So again, thank you, Sanchia. Thank you, Stephen, for your time and for your efforts today. So if I may do my usual promotion for the next sessions, and I think that'll be on the 8th of September, same time, starting at 12:30. We're going to have Professor Ziegler and also with David Thomas from the Govern to speak to us about a very different subject on personalized medicine. So I look forward to welcoming you to our next session of Roundtable again. So have a good day and thank you and goodbye. Terrific. That's been a great session, Sanchia and Stephen. I think this would be our most well-attended sessions. We got about 100 participants joining us.